From the JAMA Network, this is JAMA Otolaryngology Head and Neck Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Otolaryngology Head and Neck Surgery.
Hello, everyone, and welcome to our listeners from around the world. Welcome back to the JAMA Network podcast series. I'm your host, Dr. Paul Bryson from the Cleveland Clinic, where I direct the Voice Center. And today I'm delighted to welcome to the podcast three colleagues, Dr. J. Piccirillo, Editor-in-Chief of JAMA Oto and Vice Chair of Research at Washington University's Department of Otolaryngology Head and Neck Surgery, Dr. Donald Lanza, Director of Sinus and Nasal Institute of Florida, and Dr. Kristine Smith, who is a rhinologist at the University of Utah. So welcome, everybody, to the podcast.
Thank you. Good to be here.
Thank you.
Thank you very much.
Well, for today's episode, I'm delighted to talk about a trilogy of articles and a commentary on balloon sinus dilation. It's going to encompass three specific articles that are going to be put out around the same time. The first will be 6 sinus balloon sinus dilation, and that's an evaluation of practice patterns by Dr. Smith. By Dr. Alex Romashko, we'll look at preoperative CT utilization in patients undergoing balloon sinus dilation. And then finally, we're going to look at balloon sinus dilation utilization, where Dr. Piccirillo is the senior author. And finally, Dr. Lanza will provide invited commentary on this. So as we dive into the podcast, why don't we take a look at balloon sinus dilation? Who wants to take a swing at just kind of describing it for the listener? I know we have a bunch of educated listeners, but I thought we'd talk about utilization, but we might as well give a little introduction as to what exactly is it.
It's a technique where you have a catheter with a balloon at the tip, the distal tip, and you place the balloon within the sinus opening or through the area where the sinus opening is meant to be. And then you inflate the balloon at the tip of the catheter, and it crushes some bone when it does that. It's very forceful, the balloon. Becomes like a little pebble or rock inside the sinus. And it can cause some damage around the tissues, although it's presumed to be safer than regular FES, functional endoscopic sinus surgery. And this was FDA approved in 2005 for use for diagnosis and treatment of sinusitis, chronic sinusitis, recurrent acute sinusitis were the reasons for it, particularly the sphenoid, frontal, and maxillary, not the ethmoids.
And is this something that's typically done either in the outpatient awake setting or both there and in the operating room?
It can be done in either location, but it was originally proposed to be done as an outpatient. Many patients have suffered pain during the initial rollout of the tool. Therefore, many physicians do it in the operating room under general anesthesia or heavy sedation.
Well, thank you for that background. And, as we kind of see what the state of the art is now, Dr. Piccirillo, do you want to lead off and talk about the utilization patterns?
Sure. Thank you, Dr. Bryson. Maybe to continue to set the stage a little bit, in 2018, the American Academy of Otolaryngology and the Academy of Allergy, Asthma, and Immunology, they convened an expert panel, which I participated, to develop a clinical consensus statement on the use of balloon dilation of the sinuses. And based with that consensus statement in 2018, the first thing we looked at with this new data, Medicare billing data from 2022 to 2023, was utilization. And so we analyzed balloon sinuplasty utilization among 6,200 otolaryngologists around the country, treating nearly 500,000 patients with chronic and recurrent rhinosinusitis. And again, our goal was to see in what way has utilization changed since the 2018 clinical consensus statement. And our main findings was that overall, there's low utilization of balloon sinus dilation. Less than 3% of the patients with chronic and recurrent rhinosinusitis received the balloon sinuplasty within 6 months of diagnosis. 75% of otolaryngologists had never performed a balloon sinus procedure. And we saw a concentration of high volume outliers with less than 2% of the physicians, so that's 96 physicians out of the 6,200, performed nearly 50% of the balloon sinus procedures. 29 physicians performed balloon sinuplasty on more than 40% of their patients, which accounted for 20% of all procedures, while these physicians only diagnosed 2% of the patients with chronic and recurrent rhinosinusitis. Balloon sinus procedures showed no meaningful differences by physician gender, geographic region, years in practice, or practice type.
Well, thank you for that summary, Jay. Pretty interesting findings, right? I mean, many people with a diagnosis, but a very small group of super users, if you will.
Exactly. The pattern suggests overutilization by a small group of physicians. That's right.
Yeah, very interesting. And then, when you think about these things, are there other sort of correlates and other specialties when you were kind of looking at this? Are there sort of super users or overusers of other sort of not new, but newish technology?
Yeah, actually, there were. The company that we worked with and from whom we got our data, Global Appropriateness Measures, had worked with the American Academy of Dermatology, and particularly the Mohs surgeons, and they analyzed the number of procedures performed per patient as part of the Mohs procedure. And apparently, the national average quality measures say about, on average, 1.2 procedures is about what's required to get clean margins by Mohs. And they found a small group of Mohs surgeons also were using quite a bit more than 1.2 on average. So 5, 6, 7 times to get clean margins. And so, yes, this pattern of overutilization by a small number has been seen in other specialties.
Yeah, very interesting. And I want to dovetail that into, balloon sinus, the sixth sinus, like all of them, right? Dr. Smith, what did you find in your evaluation of practice patterns? Did it seem to jibe with Dr. Piccirillo's findings? Can you share with the listener what you found?
So, a lot of this work stemmed out of an interest in identifying different types of practice patterns when it came to looking at the use of balloon sinus dilation across the US. And one of the questions that we had is how often are patients who are having a balloon sinus dilation having all 6 of the sinuses that are amenable to balloon dilation being dilated at the same time? One of the reasons we wanted to look at this is because, as Dr. Lanza mentioned, the ethmoid sinuses are not amenable to balloon dilation. And so we imagined that the proportion of patients with sinus disease who would be appropriate candidates for having all 6 sinuses dilated would probably be low. That was one of our initial hypotheses, but we wanted to dig into that. And when we looked at this, we pulled data over a 2-year period of time. Ultimately, what we found is there are about 500 otolaryngologists performing multiple sinus dilations as a part of their practice. And between this group of otolaryngologists, they performed over 21,000 balloon dilations in that period of time. And one of the interesting findings that we found is that 60% of patients who were undergoing a balloon dilation procedure had all 6 of their sinuses dilated, meaning the bilateral frontal, maxillary, and sphenoid sinuses. Very similar to Dr. Piccirillo's data, we found that 40% of the otolaryngologists, comprising about 7% of this cohort, performed balloon sinus dilation in 100% of the patients that they did balloon sinus dilation procedures on, and that there was a very small proportion of physicians, 1.5%, only 8 surgeons, who actually performed 10% of all of the 6 sinus balloon sinus dilations over the study period. So a very similar pattern in utilization to our gross utilization study.
Yeah, I mean, that seems is very interesting, right? As a non-rhinologist and non-balloon sinus user, but as, someone who looks at CTs and things like that, I mean, it seems, I guess I would open it to the group. How often do you see all the sinuses that are amenable to dilation impacted by disease? And so I don't know if it's reasonable to question, well, is it always 6 or is it sometimes 1 or is it 2 and not 6? Is there any sort of pattern of purposeful use for this?
Yeah, it's a good question. It's hard to dig into the exact details of the motivation behind these practice patterns, but there were two things that kind of jumped out when we talked about this as a group and we're putting together the manuscripts. One is that rarely is the practice of medicine that homogenous, is it that consistent? Even in my own practice, not every person that I perform sinus surgery on has the exact same surgical procedure each time. Some patients might only need a unilateral surgery. Some patients may not have disease in their sphenoid sinus, and so we don't open that sinus. And so we see a little bit more variability in the management of chronic rhinosinusitis from a endoscopic sinus surgery perspective. And then one of the other fun facts that was pointed out in our group is that there is anatomic variation in the pneumatization of the sinuses. And so there's a fair amount of patients who have frontal sinus aplasia and are actually missing sinuses. And so having that degree of consistency really struck us when we looked at this data.
And while we don't have the other author with CT scan utilization, are either of you able to share some information on CT scan utilization as, I guess, as a way to inform these balloon sinus dilation practices?
Sure, I'll go ahead. What we found on that third paper, the CT scan utilization, is that the pre-procedure CT imaging was not available in almost 3,000 patients, which represents 15% of the cohort, did not have the CT scan imaging beforehand. And notably, 30 physicians, about 6%, did not have imaging in greater than 50% of their cases. And that represents almost 2,000 or 10% of the total cohort. So there were a large percentage of patients who weren't getting CT scans prior to the balloon sinuplasty. And on the guideline panel, again from 2018, that was really something that we felt strongly should be done prior to the procedure. And it was not being done in a large number.
Yeah, so I mean, just sort of as a non-specialist rhinologist or I don't perform this in my practice, but as a listener here today, I'll kind of direct this to Dr. Lanza. Is this a cautionary tale? Is this an opportunity for more quality and sort of appropriate judicious use of this technique?
Yes, very concerning treatment of a patient, because you need the roadmap on each individual as to where to put the balloon, because you cannot know where the frontal sinus opening is going to be or the sphenoid sinus opening is going to be. So you need that to know what the anatomy is around it. There may be dehiscent skull base there, and you might apply it. There might be a medial orbital wall that's very far medial into the ethmoid, and you might be bunking that and causing problems with vision. These are all parts of the reasons why we get CAT scans when we operate, to prevent damage unnecessary to the skull base and the orbit. And this is a dangerous pattern. Dangerous.
Any thoughts, Dr. Lanza, on the utilization information provided by Jay and Kristine? Were you surprised to see this and to hear it?
Yes, I was surprised to learn that there was so much going on right under our noses, so to speak. I think that there's a concern here, and I think that this is a pock on the face of rhinology.
I guess as like a call to action, how do we, I think the first part is doing this work, doing this important sort of utilization work and disseminating it. What are the guardrails that, we can?
We have no guidelines. I think we're far enough along that the Academy of Otolaryngology Head and Neck Surgery could initiate theoretical opportunity for guidelines to be created. We have a consensus statement, which Dr. Piccirillo co-authored or was a senior author on the paper. And that's a starting point, but they were not even followed because those are consensus statements, not guidelines. And if it's a guideline, it's a stronger note on how the patients should be treated, stronger indication than the consensus statement.
To follow up on that, what is the role of the professional societies to go even beyond that and to address these practice variations? What can be done? I cited what the American Academy of Dermatology did with the Mohs surgery overutilization problem, and there are similar strategies that our professional societies could do also.
I think a lot of the focus of discussing this work is about ways in which balloon sinus dilation may not be being used in the most optimal way But it's also important to recognize that these are really helpful adjuncts, really helpful tools as a part of our practice as rhinologists. And there are cases, patients, surgical moments where having access to these is really helpful and can really impact patient care. For me, I have a patient who's got a really hard frontal sinus to keep open. And the way that we've managed to keep him out of the operating room is by redilating basically every 18 months, and he feels great and it stays open. We don't have to go back to the operating room, which is wonderful. But if we have a tool that's not being used appropriately, particularly one that is associated with a very high reimbursement, if we don't make a point of managing the way that we're using this tool amongst ourselves, at some point we risk it being taken away from us, which would be a real loss because it does have some very positive functions in the way we treat our patients.
And again, just, a follow-up to that. Have you seen payers or other sort of insurance providers begin to scrutinize these techniques and options?
One of the co-authors of our commentary, David Kennedy, has indicated he's been in the room where there's been discussions with insurance companies about this subject. They feel that there's something wrong going on in otolaryngology, and that will be a sign that there's going to be some issues.
Well, I really appreciate all of your expertise with this and this important work, and shining a light on something that I certainly try to stay up to date with the literature, and I know this technology exists, but I don't always know sort of the conversations that are going on and the utilization. So I really applaud all of your efforts to do the right thing for patients, particularly when it comes to this. As we look to wrap up today's episode, any take-home messages or things that you really want our listeners to take home and remember?
Well, if you're a physician doing this type of procedure, you should never do it without a CT scan. You should always test for allergy before you bring somebody to the operating room, figure out what they may be allergic to and treat them that way. Do everything medically possible before making the choice that you need to use a balloon, because it's not risk-free and you shouldn't be using it all that often.
Yeah, I think the balloon sinuplasty trilogy has really highlighted the overuse and misutilization of this technique. I would hope it's a call to action for our professional societies to do something about it.
My last plug would be that if someone who's doing a high volume of balloon sinus dilation or any balloon sinus dilation hears this podcast and listen to it, go take a look at the data in our paper, see where you fall into the practice patterns that are becoming clear in the US. And if you're in that group of outliers, have a hard look at your practice and see if there's something you can do to really optimize the use of the tool and maybe come a little bit back more towards the use that reflects general practice in that way, because sometimes folks don't even know that they're maybe not doing whatever else is doing.
Yeah, all great points. Really, thank you very much for joining today.
Thank you.
Thank you, Dr. Bryson.
Thank you.
Well, I'm Paul Bryson, and I've been speaking with Doctors Kristine Smith, Donald Lanza, and Dr. J. Piccirillo about balloon sinus dilation. You can find a link to the articles in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.